Well, I was asked to show one or two cases if there was time. And here is the first one I want to show, and I'm going to go through it very, very quickly. And it's a simple case, a simple clinical case, and it's a typical case we all see of someone who, no matter what we do, doesn't do well, and clearly is a patient who doesn't like taking drugs very much, and will always find some reason or excuse not to take them. So this woman, she's 57, postmenopausal. Her GP got frustrated with her and sent her to our clinic at the medical school. She had a 10-year history of hypertension, and you can see this second bullet here. She had received all sorts of different blood pressure drugs, but she always finds some reason she doesn't like the drug, all sorts of side effects that we know couldn't really be caused by a particular drug, but she gets it and complains about it anyway. Somehow she was still taking, if you could believe it, 3 drugs, which always worries me when someone's taking 3 drugs and the blood pressure is not really responding. She was on an ACE inhibitor, she was on hydrochlorothiazide, the beta blocker, metoprolol. For no particular reason, metoprolol. She didn't really have the sort of background that would justify a beta blocker. And she was complaining of abdominal complaints, that she had no energy. She was feeling depressed. And the referring doctor, of course, he suspected poor medication adherence. And in fact, didn't suspect, she knew actually, because there was evidence that prescriptions were not being filled or refilled as you would expect them to be if someone was taking their blood pressure medicines on a regular basis. The blood pressure when we saw her, 156/98, not super high, but somewhat worrisome. A BMI 26, okay, a little overweight. In America, that would actually be considered a good BMI. In other parts of the world, not so good. But let's say she's not obese, at least not by American standards. Nothing remarkable on her history and physical exam, but there was some voltage evidence. We couldn't do an echo, and I'll mention that in a second. Voltage changes suggestive of some left ventricular hypertrophy. And on physical exam, I thought her PMI was also a little bit displaced to the left. Routine labs were normal. Her LDL cholesterol was 114. And these days, people like to have a lower LDL cholesterol than that, particularly if other risk factors are going on. Why didn't we do an echo? And the reason is that this was a lady who had an insurance plan, a government insurance plan, that makes you get a pre-authorization before you can do what they call special tests. An echo does cost obviously more than doing an electrocardiogram, and since we didn't really have a compelling reason to do an echo, we didn't have a valve problem we were suspecting, or a heart failure issue that we wanted to elaborate. In the end, I could have gotten an echo, but it would have taken a lot of effort, and at this point, we decided not to fight that battle. Interesting, isn't it? It's politics and finances that get into the practice of medicine just as much as science. Okay, patient's common problems. She's susceptible to side effects, even if she only imagines them, reluctant to take medications. So what were you going to do? We decided to stop her medications. Just stop them, see exactly what her blood pressure is, and go from there. And so we checked her blood pressure every week or so over the next 3 weeks. She'd come to the clinic, one of the nurses would check her pressure, and it never really changed. It was about 158/98, and she had some home readings that were a bit less than that. So what was the next thing to do? How were we going to restart her hypertension treatment? So that brings us to the whole issue of looking at angiotensin receptor blockers, because I decided that she would have to be started on an ARB, not an ACE inhibitor, and not anything else. ARBs are the one class of drug where, compared with placebo, they actually have fewer adverse events. So I feel totally confident with an angiotensin receptor blocker. In fact, we're looking here at data from a very large network meta-analysis done by Dr. Franz Messerli, and compared with diuretics, which when used by themselves, I'm not talking in combination with ARBs or ACE inhibitors, but used by themselves, diuretics are not very popular with patients. They're the least likely drug for patients to continue taking over time. Beta blockers a bit better, alpha blockers a bit better, calcium blockers somewhat better, ACE inhibitors somewhat better, but best of all, ARBs, better than twice as likely when compared with a diuretic alone to still be taken by patients a year after the treatment has begun. That's a huge finding, isn't it? I mean, you look at this, and clearly an ARB should be your foundation drug whenever possible, simply because it's so well tolerated and associated with much greater acceptance by patients. Why Azilsartan? Well, it's the most powerful of the blood pressure medications. It binds very tightly to the AT1 receptor, and it works very powerfully for the full 24-hour period. It also has some other mechanisms. It enhances the efficacy of angiotensin 1 through 7, which is a 7-amino acid peptide that also may be vasodilatory. I don't want to get into that. It's a complicated story. And the third other reason that it may be particularly powerful is it may enhance the way the kidney handles sodium. This is just a look at the in vitro binding capacity of the angiotensin receptor blockers. Azilsartan, you can see there's a number next to it, 2.6. And every other drug, telmisartan, olmesartan, irbesartan, valsartan, have higher numbers. In other words, you need relatively more molecules of any of these drugs to get the same binding to the angiotensin receptor that you achieve with azilsartan. It is intrinsically has the greatest affinity and binding strength to the receptor at which it works. Just to take a very quick look, I don't want to waste time talking about these sorts of things too much, but if we look on the right side, this is a comparison. B is baseline, and patients were randomized either to candesartan, which in Europe is quite a popular angiotensin receptor blocker, or azilsartan. And what we're looking at is the fractional excretion of sodium. This is a measurement of urinary sodium excretion. And you can see that azilsartan actually increases the kidney's ability to get rid of salt. And that may be very helpful, obviously, in getting blood pressure under control. We see that when we look at the blood pressure, indeed, azilsartan was quite a lot more effective. In fact, candesartan got the pressure down to 111, azilsartan down to 103. So interesting. This is the look at some comparisons now between azilsartan and other drugs. This was a look at patients randomized to treatment with azilsartan or the very popular ACE inhibitor, ramipril. Remember, ramipril was used in the HOPE trial, had very nice benefits in high-risk cardiovascular patients, and it became a very popular hypertension drug, and it works quite well. But look at what we found in terms of clinic blood pressure after 6 months of treatment. If you look at systolic pressure on the left, this is azilsartan. This first column, azilsartan 40 milligrams, azilsartan 80 milligrams. And by the way, just so you can see, some studies use 20, some use 40, some use 80. There's very little difference between 40 and 80 of azilsartan. And even though in the United States, Azilsartan is generally recommended by the FDA that it should be started at 80 because it's got no side effects that are different from any other dose. Frankly, I have gotten into the habit of using 40. The difference between the two is trivial in terms of blood pressure effect. But look at Ramipril, 10 milligrams, the standard once-a-day dose. We're looking at a little over 20 millimeters of mercury with Azilsartan, only 12 with the Ramipril. Well-tolerated drug, good drug, Ramipril, but clearly you get a lot more efficacy with the Azilsartan. And the same sort of story, obviously, when we look here on the right side, when you look at diastolic pressure. Well, what about Azilsartan compared with Olmesartan? Because until recently, Olmesartan was regarded as the most powerful of the angiotensin receptor blockers until Azilsartan came along. Well, is it better, Azilsartan, than Olmesartan? And here's a paper that was published in the Journal of Clinical Hypertension back in 2011, one of the very first studies with Azilsartan. It was a brand new drug coming out for the very first time. And when it was compared with Olmesartan, if we go from left to right and looking at the effects on systolic blood pressure after a few weeks, 6 weeks, here's placebo, just a small change. Then we look at Azilsartan 20. Then we look at Azilsartan 40, Azilsartan 80. A little bit of a difference now between 40 and 80. It varies from study to study. Some people who like using 80 will say, I told you so. And you can see that in this particular study, 80 was better than the maximum dose of Olmesartan. This was a fairly small study, and it was repeated in a classic trial reported in Hypertension, the main journal that deals with hypertension around the world. It's the Journal of the American Heart Association, in which Azilsartan now is compared with Olmesartan again and Valsartan. And let me just, again, walk you through these results because it's a little hard to figure out what's going on. Let's just look at the systolic. First of all, in this gray column, placebo, about 2 millimeters of mercury. Then we have Azilsartan 40, Azilsartan 80, again, not much difference. Then we have the very popular Valsartan, used to be very popular at least, in the dose of 320, which, by the way, is its absolute maximum dose. I think that's the maximum dose in the States. I think in Europe, it's very rare for it to be available in a dose of more than 160, but we're using it in its very top dose, and clearly it does not do anywhere near as well as the Azilsartan. And there's also a difference of 3 to 4 millimeters of mercury when we look at Olmesartan compared with the doses of Azilsartan. And a similar picture again with diastolic. So this is the first time that a new drug in a class, and this is obviously the ARB class and obviously Azilsartan, has been shown right from the beginning to be clinically superior to its two main competitors, at least in the States at that time. So getting back to our patient just for a moment, we decided, come on, let's get going here. We decided we stop everything, and we, as I already told you, we decided let's perhaps consider an ARB. So we promised the patient we'd keep her blood pressure treatment to 1 pill a day. We started Azilsartan 40 as a single drug. Wanted to be cool and calm about this lady. And the pressure, which had been 160 over 98 the day we started treatment, came down to 144 over 90. A really nice start. And believe it or not, the patient was happy. She had no complaints. And I thought for a moment, maybe I'll just leave her at 144 over 90. It's way over where she should be at around 130, but she's happy with it. She's not complaining. This is better than she's been in a long time. Maybe I shouldn't be too ambitious. You know how it goes. So I switched to the combination of Azilsartan 40 and 12.5 of chlorthalidone. And I also decided to start atorvastatin in a lowish dose, because that 114 of LDL cholesterol is below what they recommend these days, which is less than 100 for anyone who's got any sort of risk factors going on, and less than 70 for anyone who's got multiple risk factors or has had an event. So what we had after we made that change was a very nice blood pressure of 134/84. And that, my friends, is where I've left her. I'm not going to do another thing. I'm thrilled with this result. She's happy, just one pill for her blood pressure. And her LDL cholesterol is down to 78. Again, no side effects. She's happy, I'm happy, a good result. And it's all really built around our use of Azilsartan.